Okay, we have plenty of time for comments, questions from the audience. We have a great group of people here attending, really a nice cross-section of people, policymakers, providers, consumers, advocates. Bob?
Another question I have is, how do you capture, being that we have the ICFMR silo and the nursing facility silo, and when you talk about need, you're capped by the institutional dollar, even though many people who have the
Can you repeat those questions?
level have a higher need, but we have the ICFMR institutional model, which is 3 times higher, and so that even though people in that category have maybe an expanded need, but because of the way we have the silos, and we always look within the waivers, this way, instead of looking what need would be if we had a functional system. I mean, how can research get to that? Because our funding sort of sets us by label rather than actual functional need. And I'm just wondering, for future study, how we can move towards, instead of just because you have an IQ score, what's the difference with someone with a stroke, Alzheimer's, brain injury, who may just have the unfortunate thing of having that happen after age 22?
Short question, can you repeat it?
Martin, you want to try that?
I think it's
Since
Mitch.
it's
It's about me.
Mitch, okay.
Don't fight over it.
Well, in the data that I presented, that covers all the diagnostic groups that you mentioned, Bob. So that's in there. It doesn't, of course, do any comparison, unlike Martin's data, on expenditures or, in this case, need levels for people who are in institutions. The only thing I would say about that is that the Choice Act is intended to expand home and community, expand personal attendance services to people who would otherwise be in these silos, the nursing homes and the ICFMRs. And in our analysis of that, there was some concern that I had about how we were measuring need among people who had an ICFMR level of need. So Community Choice Act will apply to people who have either a nursing home level of need or an ICFMR level of need. And, I haven't really talked to anybody at the CBO who worked on their earlier estimate, but I think in some ways it was the ICFMR level of need that caused them to come up with such a large number of people who would be eligible. Because they were including the instrumental activities other than the classic ADLs. But I did do a little bit of research and found that most of the people who were in the ICFMRs do have a need for help with ADLs, and also crosswalk that with Charlie Lakin, who's an expert on the IDD population. So, I think we'd all have better data sets if we didn't have the silos and we had, ways of collecting data that covered both institutional and non-institutional populations.
Right, I think the silos are related to all the complex rules about the cost, showing a cost savings in order to have a waiver. And so it creates, it makes these silos more difficult because every state has to go through these complicated cost formulas to show savings. So I think, moving more toward a personal care program without the waivers would be helpful in that sense. Okay, any other?
Mike first got a question.
Okay, we need you to take the microphone, or
he's got it
Judy's.
over here. I'm
Well, let's
sorry.
go with Judy first.
Can you introduce
Because,
yourself?
yes, say your name and,
Okay, Judy.
and because we're on webcasting, so you have to speak into the microphone.
Okay, Judy Chamberlain from the National Empowerment Center. And if we're talking about a silo of people who are off over there and never seem to get into this discussion at all, was pleased to see one mention on one of the slides, but people diagnosed with mental illness, many of whom could benefit from personal assistance, but who largely are excluded because of certain definitional and preconceptions about what they're capable of. In some work that I've just been doing, I discovered that the state of Oregon is now serving 600 people with psychiatric disabilities and is ramping up to get to 1,000 by next year. So it can be done, but I'd love to hear some discussion about how we get to include people with mental illness in this population of people who would be considered eligible and who could benefit from personal assistance.
Okay, anyone want to, on the panel or in the audience, want to take that on? Is the Oregon program, is that under the waiver? I think there are only 2 mental health waivers. Isn't that right, Martin?
It's very few.
2 in the whole country, and hopefully those may start expanding. Do you want to, okay, here's somebody that wants to respond to that, but we need you to,
There's a
here's the
standing
mic.
microphone right behind you.
you.
There's 2 standing microphones in the room if you want to get to it.
CMS at the recent New Freedom Conference spoke about the 1915I option as a way that they believe that programs for people with severe mental illness can start coming into the waiver world. And I'll also point out that just a few weeks ago, CMS approved a state plan modification for Iowa for home and community-based services.
Okay, do you want to say who you are?
Oh, I'm sorry.
Okay,
I'm Deb Potter. I was introduced this morning, but I'm with AHRQ. Thanks.
yeah, okay. Okay, Mike?
Does that work there?
Okay.
Go back on Mitch and kind of Bob's point about functional assessments, and I hope maybe you guys can think of a way to look into that, because when the Community Choice Act passes in this Congress, it's going to require a functional assessment under federal law, which will apply to all the states, and we really need one. At home, just recently, my center, we do assessments, functional, objective, completely objective assessments. Anyway, we did one on a young woman. We determined she wasn't eligible for the waiver. Not something we wanted to do, but we're supposed to do these things objectively. And you ask all these questions and write them down and get a score. That's the requirement. Well, she didn't like the answer. Don't blame her. She thought she needed assistance, and we determined she wasn't eligible. So she appealed and did some things and basically went down the street to a home health agency who did the very same completely objective assessment, probably using their professionals, nurses, and certified people that we don't have. And they determined that not only was she eligible, but her score was twice as high as the minimum that we determined she didn't meet. And I don't know. I mean, you know, there's this appeal thing going on, but the point is, here's this objective functional assessment asking all these things and wild variation. Now, the issue of if you pass, the agency, home health agency is going to get money. I'm sure that had nothing to do with it. Anyway, there's a big need there and some way to really look at that, because that's going to obviously have a huge impact on whether people qualify and really what they're going to get. And this is just one case where there's obviously wild variation. So is that something you guys can?
I think that's a really good point, Mike, that we've seen in our studies of states where many of these, states have multiple waiver programs, and so many states are using different assessment tools for each waiver program, and then for personal care and home health. So you have so many different assessment systems there, and so there are only a few states that have really tried to pull that all together. I think Washington's a good example, and I know Mary Jane is here. I can't quite see you right. Oh, but I know you've worked on the assessment tool that's being used by a lot of states, so I don't know if you want to make any comment